So today I'm going to talk a little bit about the difference between ventilation and respiration. For the most part, people seem to use the terms interchangeably, but they're actually two different terms that mean two different things. And what you are probably seeing in textbooks, what you probably will read on EMS charts, is that every time someone records a respiration, that is usually what they're counting. And technically, that's incorrect. The the way to actually count someone's breathing is actually you're counting their ventilations. And the difference basically is this. If you look at what a ventilation is an actual breath. That's the physical movement of air going in and out of the respiratory tract. So one inhalation and one exhalation, that's one ventilation. So that's one breath. And that's what you're actually counting. Respiration is a little bit different. Respiration is an exchange of gas inside the body across a membrane. So if you can count those things, you have somewhat of a microscopic vision on life and you're pretty good at it. But that's something that we obviously can't see externally. Simply put, when we look at what a ventilation is, it's just that, it's breathing. It's when we take a breath in, when we let a breath out. Basically exchanging gas with the outside environment outside the body. Now, to do that, air's got to pass through a number of different structures to get all the way down to the alveoli. And what you see in a lot of respiratory diseases is there's an interruption of ventilation at some point. The key is that it doesn't make any difference where the blockage is. You know, if it's in the nasal passage, if it's in the larynx or the pharynx, if it's in the main bronchi, if it's in the other bronchioles that eventually lead down to the alveoli, if there is any blockage between point A and point B, that interrupts the ventilation, that movement of gas and air, per se, outside and inside the body. So when you take a breath in, you're actually seeing chest rise, and that's what we're counting X number of times per minute to get a ventilation rate, or what everybody calls a respiratory rate, which obviously isn't technically correct. So how does it happen? Well, you can hold your breath, and for a certain amount of time, you'll be able to do so until your brain figures out that you're not breathing, or enough carbon dioxide builds up in your bloodstream and tells it, well, you know what, you need to take a breath. So the brainstem in and of itself is the main control over everything. And at the base of your brainstem is a structure called a medulla. And that is what basically sets the rate that you're going to be breathing at, and you do it unconsciously. And for an adult, you're looking at something between 12 and 20 times a minute. And as you look at a younger patient, those rates get faster simply because, one, their lungs are smaller, so you need to move more volume. You have to breathe faster to make up for the difference. The second thing is that their metabolism, when they're younger, is much faster and has more oxygen demand. So to make sure that that happens, you breathe faster and also get rid of that carbon dioxide that their metabolism is producing on a much larger basis than, say, for an adult. All right, so if the brainstem medulla portion fires, then what controls your rate is the piece right above it in your brainstem. It's called the pons. So there are times when you have to breathe faster or breathe slower, depending on situations. If you're out exercising, body needs more oxygen, needs to get rid of more carbon dioxide. So the pons will accelerate your breathing, overriding what the medulla does temporarily. Now, once that demand isn't there, pons kind of shuts itself off, the medulla takes back over again, and we're back to where we were. And vice versa, if we're, say, going to sleep, we don't need to be breathing as often because we're just lying there and we're not really doing a whole lot. We don't have as much demand. So in that case, the pons will kind of slow our breathing down to the point where it's still adequate, but it's not normally going to be as fast as what we would have as we're awake. So that's all fine and dandy. But if that signal that's coming from the brainstem, one part or the other, doesn't get down to the structures that actually inflate the chest, then it doesn't do us any good. And what has to happen is that once the brainstem activates an impulse, travels down with its attachment right at the base of your skull to the spinal cord. and it will travel down the spinal cord till it gets down to, depending on who you talk to, somewhere between your cervical nerve number 3 and number 5. Usually those 3 on either side of your spinal cord pick up the signal then, and then left and right, they send it down one large nerve, which is called your phrenic nerve, left and right. It's like a pair of suspenders, what it kind of looks like. That impulse goes down to your diaphragm, and that's what actually makes your diaphragm work. Now, not to be offensive, because it's true for everybody on this planet, right? Yours, mine, everybody else in your class, everybody that you work with, all your family members, your spouse, everyone. Okay? Your diaphragm is nothing more than a dumb piece of meat, right? It has to be told what to do every day, all day, 24/7, 365. Because if it's not told what to do, it's not going to do anything. It's very, very lazy in that respect. So the problem is that you have to have this constant impulse coming from the brainstem, coming down through your neck, into the spinal cord, out the nerves that come along your neck here, and then go down your chest, and then fire the diaphragm. Now, once the diaphragm is activated to basically contract the diaphragm, it expands outward. So what happens is that it normally looks like a dome like this. What happens is that it goes like this and actually pulls the chest and the thorax down towards your feet. And what that does is increases the space in your thorax a little bit more than what it normally is. Now, why does it do that? Well, what we're trying to do is we're trying to create a pressure gradient that's different from the outside. Because if you know anything about diffusion, the simple fact is that something will move from a high to low concentration, and it'll keep doing so until things are met and they're equal. Now, changing the volume of the thorax by dropping that diaphragm down actually decreases the pressure inside your thorax. Now, it's not by a whole lot. Normal atmospheric pressure is about 760 millimeters of mercury, give or take. If you hold your breath, none of your muscles are firing, that same pressure then exists inside your chest. So no air is going in, no air is going out. But if I take that diaphragm and drop it, that opens up my chest a little bit, and it actually creates more space, which then relatively drops the pressure because there's not as much tension in there. So it just kind of opens things up. That's part one. Now, part two involves your intercostal muscles. And there are a bunch of different sets that exist beside your chest, but the external intercostals are the ones that we talk about the most. And so what you will see along with that diaphragm that drops is that there's another set of nerve pathways that come off that phrenic nerve that will actually go to each nerve in between, or each muscle, I should say, in between your ribs, and cause those muscles, your intercostal muscles, to also contract. And when they contract, they actually expand out as well. So what happens is that not only does your chest go, expand this way, but now it expands outward as well, increasing that pressure drop even more so that now you go anywhere between 3 to 7 millimeters of mercury less than what's on the outside of your body. So when that happens, there's 760 out here, and let's say when my chest expands and drops like this, maybe the pressure drops to 755. 760 to 755, where's the air going to go? Down your respiratory tract, and hopefully all the way down to the alveoli, and hopefully bringing a high concentration of oxygen with it. Now, how do we get it out? That's the easy part, because as breathing and inhalation, which is half your ventilation, is active, because the brainstem has to do all the work and send all the messages down here and tell them what to do. To exhale, the brainstem simply just stops firing. It's like turning off a light switch. So when that light switch is clicked off, all those impulses that are going to the intercostals and the diaphragm stop going out. So the diaphragm says, okay, well, I don't have to do anything right now. So it relaxes, and now it comes back up, and your intercostal muscles aren't being told to expand anymore, so they just passively collapse. And in that short moment when the diaphragm comes up and your rib cage basically collapses upon itself, it temporarily creates a pressure that's about, again, 3 to 5 millimeters of mercury higher now inside your chest versus what's outside the body. And that then is exhalation, which is hopefully at that point getting rid of any carbon dioxide that's been built up in the body. All right, so respiration, which we're not counting, but why not? Well, as I said before, this is basically a gas exchange across a membrane. So what we're talking about specifically here is oxygen crossing either in or out of the bloodstream, as well as carbon dioxide going in or out of the bloodstream. At the alveoli and the pulmonary capillaries, that gas exchange, that respiration that takes place is what's called external respiration, because you're kind of dealing with the external air of the body, outside the body. So oxygen in this case leaves the alveoli, gets into your bloodstream, and carbon dioxide in your bloodstream goes to the alveoli. And it flips that way. Now, how does it do that? Well, there's a pressure that's created based on how well that patient ventilates. How well do they get enough air down into those alveoli? If they take an adequate ventilation, air comes down, oxygen is under a certain amount of pressure that's higher than what's inside the pulmonary capillary. And vice versa, in the external air, we don't have a lot of carbon dioxide. So in that alveoli, there's a very low pressure, very low concentration of carbon dioxide, but the blood coming back into the lungs from the body is bringing a whole bunch of carbon dioxide with it. So I've got high oxygen in the alveoli, low oxygen in the pulmonary capillary, and I got low carbon dioxide in the alveoli, and I got high carbon dioxide in the pulmonary capillary. So what do? You get the switch, high to low, oxygen comes in, CO2 goes out, patient exhales, CO2 goes bye-bye, the oxygen travels onto the heart, gets to the left side, gets to the left ventricle, and eventually gets punched out to the body, and then goes to point wherever. Once that blood now gets to a cell at some point, the scenario is just flipped. So now that blood that's in the capillaries is very oxygen rich because we just took a good ventilation and brought it out to the body, and the cell has been producing a whole bunch of carbon dioxide, but it needs more oxygen so it can keep running. So the oxygen level is very low in the cell as opposed to inside the pulmonary capillary, but the carbon dioxide level is very high in the cell compared to the very low amount that's inside the capillary. So carbon dioxide jumps in the bloodstream, oxygen jumps to the cell, and now blood keeps on moving away. The cell's happy, it does its job and uses the oxygen, makes a whole bunch of energy and keeps itself running. And that allows for that tissue that it's a part of to keep operating efficiently. And that tissue lets that organ that it's a part of keep operating efficiency. And that organ then keeps us, the organism, working and everything's okay. So what do we do with the waste? Well, we threw that carbon dioxide into the capillary, which now turns into the veins. The veins eventually work their way back into the heart, dump it on the right side, and where does it go? We punch it back up to the lungs, and we start the whole process over again. So respiration of itself works by that gas exchange based on pressures depending on how well we ventilate. So if nothing else, just remember that ventilation is breathing. Ventilation is air moving in and out of the body, and that's what we count when we look at a person's breathing. Respiration is the gas exchange that can take place because someone adequately ventilates. Just think of it this way. You look at a BVM, it's a bag, valve, mask, ventilator, ventilation device. Okay? And when you squeeze that bag, you're forcing air in and letting it come back out. We don't bag valve respirate someone. Okay? We bag valve ventilate people. So kind of think it in that terms, and sometimes it helps people to keep them straight. But you're still going to hear the terms using correctly, but hopefully you'll at least have a better understanding of the difference between the two and going on from there.